Okay, terrific. All right, welcome everybody. Glad to see many familiar faces and welcome to the new members of our audience. Thrilled to have everybody here, both live and later on YouTube. I am Becky Berman, I'm the moderator, but really we're all here to hear Glenn Grossman, who is our host. Glenn Grossman is an epidemiologist with over 20 years of experience. While pursuing his doctorate in epidemiology at UNC Chapel Hill, Glenn served as an epidemiologist on staff at the UNC Infectious Disease Clinic for 2 years, and he taught epidemiology and advanced analytics at Duke Medical School and at UNC. He has been involved in epidemiology projects with Medicare, Medicaid, the Veterans Health Administration, Military Health Service, the CDC, and other programs in the US and abroad. He is currently Senior Director of Outcomes Research and Epidemiology at Novartis, but all views expressed today are his own. So, Glenn, good to see you again. Happy Sunday.
Happy end of August. I can't believe the
End
summer.
of August. Holy moly.
It
Here
felt
we
like
are.
March and April each felt like they were 6 months long.
Yes, they
Then
did.
June came, and then July and August felt like they were just a couple weeks each, and then they were done.
I know. I agree wholeheartedly. I remember thinking at the beginning of the summer when camps were announcing they weren't opening, oh my goodness, we have the entire summer ahead of us. What are we going to do? And that feels like 30 seconds ago. And we made it. And it wasn't so bad thing, hopefully, for everybody on this call and for everyone else who's watching. Hopefully everybody's stayed healthy and safe and well, and hopefully sprinkled in some fun along the way. But, you know, how are things going? I hope you have some good news for us, both what's happening here at home and abroad. How has this week been?
Yeah, let me open up. So we're actually in good shape. Let's see. So, we're not in good shape. We're in, let's say, better shape than we were a few weeks ago. The epidemic is still out of control in the United States. So in control would be like approaching zero. Still out of control, but the good news is that we're better than we were a few weeks ago, or even a month or two ago. So we sort of, we saw, some people have been talking about a first wave versus a second wave. Across the United States, we have kind of a lot of different outbreaks. And so a lot of us now are referring to these as surges. So this is the first surge, and then this is the second surge. It's not really a traditional first wave and second wave because it never went down to zero. So it was just a continuation of the surge, or rather of the first wave. The problem is that we are heading into the fall season. And so as the traditional flu season is expected to start up, then it improves the conditions for the spread of coronavirus as well as a respiratory disease. So we can talk about that a little bit later. We do have good news about the flu. Everyone should get their flu shots if you haven't already. Usually we wait a little bit later in the year to get the flu shots because it does wane during the course of the year, particularly among those over the age of 65. It might only last, I don't know, 3 months, maybe a few more months than that. And so we want to make sure there's enough coverage for the entire flu season. So that's why we usually wait a little bit longer, but now it's good to get a flu shot now, and then maybe among those age 65 and over, if it's warranted, after discussing it with your physician, maybe getting a booster shot or something somewhere in the middle of the winter. All right, but things are better off now than they were. So over the last week, we estimate that there were approximately 250,000 or so new infections. Only a portion of these were diagnosed. Our testing is still really, really poor. In fact, one of the things that, one of the controversies over the last week was the CDC came out with new kind of ridiculous guidelines saying that asymptomatic people shouldn't be tested. And then there was a backlash because the public health community, in particular, a lot of public health organizations around the United States said that there's a lot of spread among asymptomatic people, and that's ridiculous. And so now I'm not exactly sure where it's settled, but there's insufficient testing. We need to be doing more testing. Everyone agrees we need to be doing more testing. And so it's problematic. Some states are way better at testing than others. So I can come here, give me 1 second. I want to do this. I'm looking test and trace. So if you see here, this is a dashboard that I've shown in previous weeks. This is test and trace, and I like this because this combines in one dashboard the number of contact tracers available for any positive case and also the amount of testing that's being done. And so you see, I don't know if you've noticed over the weeks, but there's actually less red over time. Some states are doing increasingly better, so they're becoming bluer and darker blue, both in terms of the testing that they're doing, as well as the contact tracing. So for instance, in New Jersey, let's see, so we have here 1.3% of tests are coming back positive, which is great news. That's what it should be. It should really be under 3%, under the lower the better. And so we really need to be doing more testing in much of the country. In New Jersey, we're doing great. We could use some more contact tracers in New Jersey. Right now, we have around 4 contact tracers on average for every positive test that comes back. So you have a positive test result, and then you have an army of contact tracers available, an army of 4 to go after each one, notify people who they might have come into contact with, and get them tested as well. And so this is, again, an example of a non-pharmaceutical intervention, an NPI, and it's a traditional public health intervention that works extremely well. This alone, if we just improved our testing capacity and our tracing capacity, this alone could mostly solve this epidemic in the United States, but we still haven't done sufficient testing or tracing. We just don't have the capabilities up in most of the country. You can see that the Northeast is doing great in general. New York has 15, almost 16 contact tracers available for every positive test to go and inform everyone what's going on. And so the Northeast is doing pretty well. When you look at other states, Florida is an example, not doing well. There's a 12.3% positive test rate. And at that, so what the reason we look at the positive test rate more than anything else is because if you have a high positive test rate, then it means that the ones who are getting tested are mostly the symptomatic people and the people who you already probably know should be in quarantine and should be left down. You're not really good when the positive test rate is this high. You can't really use this as a public health tool to help identify people who are sick even before they know that they're sick, to quarantine them and prevent this spread. When the number of when the positive test rate is so high, it's really not a very effective tool preventing spread at that point. And so and there's not enough contact tracers for the positive tests that are identified. So it's just not a good tool for preventing spread. The other tools that are more effective right now are a lot more people are wearing masks. There's more physical distancing. It's summertime, so a lot of people are spending a lot more time outdoors. And so those key things are I think what's driving most of the decrease that we're seeing around the country. Globally, I wanted to show this. So globally, when you compare, I know that sometimes the federal government in the United States says we're testing more than any other country in the world. And technically that's true. The number of tests we're doing in total is more just because we're a pretty big country. But when you actually compare, the more important metric when we look at testing is the number of tests conducted per confirmed case. This is sort of just the flip way of looking at it. So we just talked about the in test and trace, the percent positive. The flip way of looking at that is among each positive case, the total number of tests that it took to get there. So for instance, if you had 1% positive test rate, then that means that you have 100 tests for one positive case. And so you can compare this number pretty well across lots of countries. I picked a bunch here just as a sample. So you can see here's the United States on average across the country as a whole. Obviously, you saw in the state map that I just showed you that it varies dramatically in terms of how well we're testing across the states. But at the country level, United States as a whole, on average, we're around 16 tests for every positive case. And so this varies a lot across other countries. So even Sweden, which a lot of people saw as a more avant-garde approach to letting the virus go, they're still testing over 50% higher rate than we are when you look at it in terms of the ability to identify the positive cases. But then when you look in much of Europe, where they're really much more aggressive, Germany has 114 tests on average for every one positive case. I think that Australia is the global leader here. I didn't systematically look at other countries, so I don't know if there's other countries that are doing even better. If I were to guess, I would guess maybe New Zealand or Singapore or maybe Japan, but I haven't looked at those right now. But on the list that I was looking at, Australia is leading with almost 200 tests for every positive case. So they are really aggressive in testing. And if they identify a case, and so because they're testing so much, they are way more likely to identify a positive case even before the person has symptoms or knows that they're positive. And as a result, this one thing alone is responsible for keeping, let me switch to here. Let me just move this down a little bit. All right, so when you look at Australia, they're almost not even on the map. So here's Australia. This is the number. What we're looking at is the number of new cases per million. If you recall, the Southern Hemisphere is in winter right now, and that's when it's really hard to keep the coronavirus under control because it's a respiratory virus in terms of the spread. Obviously, we know that it does impact other organs like the heart, the cardiovascular system, gastrointestinal system. There are other impacts, but in terms of the spread, it's primarily through the respiratory route. And so winter is a big thing because of that, because of people spend more time indoors and the things that we've discussed previously. But you look at Australia, where it's wintertime now, they're in the Southern Hemisphere, and yet they've been able to successfully avoid a real big second wave here, which is astonishingly good, especially when you compare them to some other countries in the Southern Hemisphere. And when we wonder, well, what is Australia doing right that's led to this? And well, this speaks better than anything else. Australia, and it's even been improving. I showed you a snapshot earlier in August. When you look now at the August 27th, the most recent data point that we have, there are almost 400 tests per positive case. I'm telling everyone, testing and tracing alone, if we did nothing else but had extraordinary amount of testing and an army of contact tracers, that alone could keep this epidemic at bay until we had sufficient vaccination and treatments and things in place. But it requires federal investment, and we're really not there in the United States. We've really failed. When we look, let me focus in on a few. Let me get rid of Australia. I'm going to look at confirmed cases here. So if you look now over the last, the last month or so, so July 29th to today, you can see that the Southern Hemisphere relative to the rest of the world is in pretty poor shape. So Peru, Argentina, Colombia, Brazil, they're heading up where most of these countries are in terms of the new diagnosed cases per million. Spain has been creeping up over the summer. They're really to get it under control. Chile, you see, is another one. But the United States, I mean, outside of Spain, as the exception from Europe, the United States should not be comparable to South America right now, because South America, it's wintertime. And so now the worry is, I'm going to switch to this one, not that one. So I've shown you this dashboard before. Here's the United States. Let me just get down to where we are. So here's the US. The worry was we had our first surge. We never got down back to near zero. So therefore, when the second surge hit, it was at a new floor. The floor was already still high, and we just went up from there. The worry now is that we've had the second surge. We're going down some, but we need to get down as far as we can before fall and winter, because when fall and winter hits, the traditional flu season, so beginning around middle of September, October-ish, when the flu season typically starts, that's going to be our new floor for what comes next in the fall and winter. And so we're really hoping we can get down. There's no way by middle of September, October, we're going to get down to 0 at this point. So that means that the third surge that's coming from the fall season is going to have a new floor somewhere, and it's going to go up from there. And that's problematic. But I mean, it is what it is. It could have been avoided, but it was a failure of federal leadership. All right, let's see. Was there anything else I wanted to talk about here? Oh, so the one other thing is, so this, I have sometimes shown this website. This is looking at the effective R. This R is based on diagnosed infections rather than the estimate of the total infections. And as we know, because testing is so poor, the actual infections is very poorly estimated, because we're just looking at diagnosed. And diagnosed, it tends to be that as the surges occur and testing drops, the number of infections relative to the testing actually increases as a proportion. So we actually have less visibility. Whereas when we came back over here, at points in time, like over here, where we had a drop in the surge and there was a greater percentage of tests in terms of the for each positive case, at this point there could be more confidence, for instance, that we were that the ratio between the diagnosed cases and the infected cases was closer. But as we start surging again, then that ratio gets worse. I think that's it for this week. Let me just see if there's anything else. One thing just to point out, I mean, so this is good news. If you'll notice over the weeks when we've been looking at some of these dashboards, there was a lot more red. And in this dashboard, you see a lot more orange rather than the red. I mean, and that's good news. And so we still have a ways to go. We can't say that this is under control in any way. Under control would mean almost 0 cases. So it is still an out of control spread, out of control epidemic, but it's not spreading as bad as it was even a month ago. So that's good news. But when you look at a different dashboard like this one, which uses, so that the dashboard that we're looking at here uses the original criteria that the federal government suggested back in February, March, I think closer to March, in terms of the proposal for reopening. And the 3 simple criteria were, how is the disease spreading? Can our hospitals handle the load? And is there enough testing being done? And when you just use those 3 criteria, then we still have quite a lot of red in this country. When you use other type of criteria that the dashboard I just showed you uses, they use some additional criteria, then it does look a little bit better. But we're not out of the woods. Fall, winter is going to be tough. That's the big story here. So, any questions so far?
Let's stay on this map. We like the good news. So I guess, are we entitled to kind of pick and choose what data we prefer you show us? Or you're in charge of showing the data, so we just have to view it and
So as epidemiologists, the way we answer any question, the very first thing we say is, what criteria should we use to decide our answer? So for instance, the criteria used for the first dashboard, which is this one, are very clear. There's 3 criteria. How is the disease spreading? Can the hospitals handle the load? And is enough testing being done? And under these criteria, the colors are a little bit different. It's not quite as good. Under different criteria, which it looks like there's whether the infections are increasing or decreasing, the total load, it's looking a lot better, and that's primarily driven because of what we just saw here. Because we're on this downward trend of this surge, that's what's really triggering most of the orange and yellow in this graph. So, but that's the same with any scientific question. It all depends on what criteria we use to answer the question, and then how do we decide what criteria to use. So almost what criteria do we use to decide what criteria do we use to answer a question. So there's almost a philosophical element to answering it. But I mean, it's positive. This is, again, it's mostly because the second surge has been coming down that it's really gotten rid of a lot of the red in the country.
Well, I think I speak for everyone when I say we appreciate you showing us the different lenses that are being used out there and how these dashboards are being compiled so that when we look at different data, when we're not with you, that we kind of keep that in mind, that the assessment is different. So thank you for that. But glad we'll take the good news, however, which way you put it together, we will definitely take it. So we'll kick it off with some questions that came in during the week. But as always, if you have questions, you can send me a private chat and I will get the questions live in the queue. But we'll start off with some questions that came in. So here we are, like you said, I cannot believe it. We are at the end of August. And what that means is back to school. Many colleges and universities are back, and other pre-K, kindergarten through 12s are opening up around the country. What do we know? What's happening? What do we expect will happen?
So yeah, so colleges have started to reopen. A lot of them opened in August, early mid-August, and so we've had a lot of colleges opening. The big news that hit, this was a couple weeks ago, was UNC Chapel Hill was open for 1 week. Then they had a couple of outbreaks, a few outbreaks on campus, and they closed it all down and went to online classes at the school. If you see this map, so the New York Times has been tracking outbreaks. I believe this was from back in February, though. This is cumulative, so I don't know that it's very helpful looking at it over the last, over the last month. But you'll see that around 750 colleges or universities in the US have had any outbreak on campus. And within the university or college system, over 26,000 cases have been reported. So as we know, universities are a very efficient way to spread coronavirus. And not just in classrooms, it's because people live in dorms, they usually have to save on rent. There's a lot of people frequently living in small households, and hygiene and other things sometimes aren't optimal. And so it's very easy to spread. In fact, if you recall, Sweden, which again, we sometimes see as this laissez-faire approach to dealing with COVID-19, even they shut down their colleges and universities back in March when everyone else shut down. So right now, the colleges and universities have reopened in most instances with higher rates of COVID-19 than there was back in March in some of these states. So it's troublesome. The key thing for the colleges and universities is ensuring that there's sufficient testing and tracing. And I don't know what that looks like at the university level. I think that New York Times might have been tracking it. I don't really know what that looks like at the university level, though. It's very different when you talk about colleges and universities versus elementary school or high school, though. The dynamics are different. Most of these kids at colleges or universities are not living with elderly parents or elderly grandparents, for instance. They tend to, they're separate. Some of the faculty and staff might be older at some of the universities, which might put them at higher risk. And so that's unfortunate and something that people need to be aware of. The other thing that we need to be aware of with colleges and universities are that when they do close down, when it becomes remote, a lot of these kids then go back to living at home with their parents again. And then they could bring the virus back into their households with their parents and grandparents. So it's tough. These are questions that are being asked in households throughout the country right now in terms of how to deal with this and whether to work remotely or try to see how long they can last going to opening the university and being in person. It's a tough situation, no easy answers. All we know is that there's a lot that the schools have reopened, and as expected, we're seeing an enormous bloom of outbreaks within the university system.
Not good. So I guess to be continued as the next kind of few weeks unfolds about what's happening at the universities, and then also what's happening in the elementary schools, middle schools, high schools,
Yeah.
etc. To be determined. So right around the time we met last Sunday, there was an emergency use authorization for the convalescent plasma treatment. And we spoke a little bit about it. But through the week, it's been politicized, and it's been a bit of a controversy. Why? What happened this week?
Yeah. So there's a couple things that have happened, but first and foremost, so last Sunday, so just to bring everyone up to speed, so last Sunday, the federal government, the FDA, made an announcement that convalescent plasma would be given an emergency use authorization, an EUA, so that physicians could start using it more as just a standard treatment for people who are infected with SARS-CoV-2. And an EUA, as we've talked about before, is sort of a backdoor to authorization under emergency situations, where it doesn't require going through the entire clinical trial schema where you have phase 1, phase 2, phase 3, and really have sufficient evidence to bring it. Instead, the level of evidence needed is just that we think more likely than not that it will be both sufficiently safe and effective that in an emergency situation we should use it. And so if you recall, hydro HQA was given as an emergency use authorization a bunch of months ago. It was touted by the federal government. And then after more clinical trials were reported in the US and globally, we realized that it was not actually beneficial and in some cases caused more harm than good. And so the emergency use authorization was removed for hydrochloroquine. And so since then, so now this is a new EUA for convalescent plasma. And so at first this is good news. The problem is there haven't been more phase 3 clinical trials for convalescent plasma. There were some early studies that were done demonstrating that it was sufficiently safe, which is good news. Just to remind people what convalescent plasma is, so after people get sick, they develop an immune response. Plasma is the portion of the blood that's after you take out the red blood cells and the white blood cells, it's the portion of the blood that remains and is rich with antibodies, but also has lots of other things circulating around. It's just a person's blood, everything left over after you take out the red blood cells and white blood cells. And so there's all sorts of potential things in there. They test it for HIV, they test it for hepatitis C and other pathogens that we might test for in blood, but there's lots of stuff in there. And so there is a safety worry whenever you make a donation like that from someone. With the plasma, there are antibodies that we find. Whoops. And so without even looking closely at the antibodies, just injecting the plasma into a infected patient is what's being proposed here. It's been used for many decades for all sorts of other diseases, and this is what we have the EUA for. Now, the problem is that when it was reported, the head of the FDA, Dr. Stephen Hahn, made a mistake, and he grossly misrepresented the plasma data, the blood plasma data, and suggested that there was a 35% reduction in mortality if patients are given this convalescent plasma. And there is no evidence to support this. He cited a Mayo Clinic study. The Mayo people at the Mayo Clinic who published the study said no, there's no reference to this at all in the study that they published, and there was no control arm in the study that they published. There was no way to say that there was a 35% reduction. It was just a broad falsehood, and the FDA should not be doing falsehoods. And so, in fact, there was a quote from Dr. Gilad. It's just a typical one. There were a bunch of people who were very upset about this. And he said, for the first time ever, I feel like official people in communications and people at the FDA grossly misrepresented data about a therapy. And so this is problematic. Since then, so first let's dig into what he said. But before I go on, there's one other thing I wanted to mention here. So an EUA, an emergency use authorization, is good if you make something available. The bad side about it is that it could potentially make it harder to enroll patients in clinical trials. The reason is, if convalescent plasma is readily available as a treatment, and a doctor says to you, would you like convalescent plasma as a treatment, or would you like to enroll in convalescent plasma as a clinical trial? If you enroll it in the clinical trial, then that means half of the people, or some portion of people, will be put on the treatment arm with convalescent plasma, and some people will be put on a placebo arm. And a lot of people who want convalescent plasma would say, no, I don't want to risk having a placebo. I want the real thing. I want the convalescent plasma. And so as a result, it makes it harder to enroll people in clinical trials, or could make it harder. And we still don't have any good clinical trials here that actually support its use. And so that means that we might be giving more people another treatment like hydrochloroquine that doesn't work, that when we could be giving them other things like remdesivir or other things that might work better. And so there is a burden as well as a benefit here. But let me go back to the controversy in terms of the overstatement. So basically, a lot of physicians all over the country and outside of the country as well have said, okay, the FDA needed to correct this statement. This is the FDA, the public health community in general has a very urgent reaction whenever we hear falsehoods. And I'll get into that in a second. But when you have incorrect information in other industries or other areas, it's bad. I mean, lying is bad, falsehoods are bad. But in medicine, something is very unique because there's a long history that's come about. And so we really are in a different place with falsehoods. And so when we hear something that's not true from an FDA, I don't know if you've read it in the news, but I've been alert in reading the news that a lot of epidemiologists and physicians and people in public health have been using words like alarming and much more aggressive words to respond to hearing a falsehood coming from the FDA. And I wanted to go into that for just a couple of minutes. But first, this is what was the study that was published from the Mayo Clinic. It was comparing people who were treated with convalescent plasma within 3 days of their diagnosis versus people who were given the convalescent plasma 4 or more days after the diagnosis, which isn't really a control group that you would ultimately, in a normal clinical trial that's a phase 3 trial, you would want someone with the treatment and someone without the treatment, which is not the case here. But anyway, so that there were people asking for the retraction and a correction. Then what happened? So the FDA did make the retraction. I don't know if you all heard of it. You might have heard that convalescent plasma was approved, but then you might not have heard after the big announcement last Sunday that there was actually a correction that was issued because it wasn't given the same fanfare as the original falsehood. And so then what happened are that the two public relations experts who had really encouraged Dr. Hahn to retract the number and apologize for the falsehood, they were then fired by the Department of Health and Human Services because they advised Dr. Hahn to retract the statement and to apologize for giving out false information. And so then this gets really bad. And that's why I wanted to now go into just a brief discussion, just for a couple of minutes, on integrity and the history of truth and lying in medicine, and why this is so visceral for all of us in public health when we hear something like this. Whether we need to sort of fence off health and medicine from anything else when it comes to falsehoods. We need to, and here's the reason. I'll go through the history. So the first history in terms of lying and telling the truth in medicine came from the Hippocratic Oath. So here you have Hippocrates, where it was really from the Hippocratic Oath, you had to have a sort of basic level of integrity in communicating with patients and working with patients. From there, You might recognize the caduceus. The caduceus originally, during the time of Hippocrates, in 500 before the Common Era, had a staff and a snake. I think I've mentioned this previously, but the staff was because unlike a physician now, where we typically go to a doctor's office to get treated, back then the doctor would come from town to town and would do home visits, and so the doctor would come to you. And so because of that, they were recognized as having a staff wherever they went. And additionally, back then, the snake was seen as life-giving and health-promoting. And so if a snake visited you while you were sick, it was seen as a good thing. So those were the two elements of medicine. Then in the early 1800s, this symbol became common. And that's because that's when the medical press started becoming more common. And there was a publisher of medical textbooks who then changed the caduceus to be creative, make it more artistic. They put in the wings. The wings are supposed to represent the god Hermes, which is the messenger of the gods, and that's where the wings came from in this. But the interesting thing is that the medical textbooks allowed the same information to be published over and over and over again, and then if there was an error, it could be corrected across everyone who read the textbook. And so it sort of became systematized. And so this was a really important step in sort of ensuring truth and accuracy in medicine. From there, the next big timeline in the United States that I'd pull out was the establishment of the FDA in 1906 by the Pure Food and Drug Act. Before this, there were a lot of charlatans out there. And so what we would typically call these snake oil salesmen, where people would just be selling any old treatment that they could, just so that they could get away with it, just that if they could convince patients to take it, regardless of whether it was safe or effective for patients. In the decades that followed the establishment of the FDA, then it was a really strong focus to ensure safety and efficacy in all drugs that are, and to eliminate snake oil salesmen. And so that there, whatever marketing gimmicks or whatever there are in other fields and medicine, there can be no marketing gimmicks. And that is hugely supported by the hammer of the law in this case. The next thing that happened was the Holocaust. And so there was a lot of medical experimentation in the Holocaust. And the Geneva Conventions in 1949 declared that it was a human right for all people to have informed consent, whether it's through an experiment or if there being any treatment. It's a human right that all patients understand what both the safety implications are for taking a drug and the expected efficacy implications. And so this human right violation that we saw in Nazi Germany, this was really one of the turning points globally in this idea of public health, of public health privacy, of integrity with public health people, but also with public health data that we work with, to the degree that anyone in the United States that even touches public health data at all, and that means that if data is collected about a person that has any health information at all, PHI, public health, personal health information, it requires that we get trained every single year on the history of all of these things. So we're literally, every epidemiologist is seeing these pictures every single year and is remembered and is reminded about the Geneva Conventions and is described why we do what we do and ensure that we have truth in medicine. And so this is not just sort of like a sideline thing. This is a core of all epidemiology that's come up, not only of the Holocaust and what I mentioned before, but it's a core. And so that's why it triggers so many epidemiologists and public health folks when we see that there's falsehood in medicine that's being represented. The next thing that happened in the United States that I should bring up is the Tuskegee experiment. And so this was, it started in 1932. It was a long study that lasted until 1972. So it went from 1932 to 1972. The problem here was during the course of the study was on syphilis. During the course of the study, a treatment became available for syphilis. And yet they didn't stop the study to treat the patients, or they didn't make the patients aware that there was a cure. And so because of that, the patients enrolled in this study were suffering and were not given the cure. And so there's a racism element to it because they tended to be Black in this community, that in terms of the people enrolled in the study. And so it was really problematic. But this also is something that we talk about every single year in epidemiology, anyone who touches any personal health information. And that's why when we come to something like this, where there's a falsehood at the top of the FDA, a patient can't make an accurate choice about whether to use a treatment if you don't have truth in the safety and the efficacy of the drug that you're getting treated. And so that's why you might be hearing like these terms. This is not something you typically hear scientists say, like using words like grossly misrepresented, alarming, other big words like this. And that's because we have because of the unique history with public health and sort of how it's developed over time, we have a unique responsibility to have integrity and truth in medicine and everything associated with it. And so this is problematic, and it's this is what happened over the last week. So I'll just leave it at that.
Thank you for taking us through that history, Glenn. Gosh, I wouldn't even think about how epidemiologists have this annual visit back to these details, and I think it's so important. And when we're reading things like a misrepresentation, wow, that puts it in a whole new light. So
yeah, the context. Because for epidemiologists, like I said, anyone working with the NIH, National Institutes of Health, that is, or any public health information, it's because it's in the front of our minds every year that we have to get recertified and demonstrate that we know that lying is bad, and that in particular, not just that it's bad, but why we would never do such a thing because of this history. That when a person at the top of the FDA does something like this, again, you have this guy who's saying it's the first time ever that the head of the FDA has said something like this. This is big. It might not seem big to someone. Oh, he just misspoke or something. This is somewhat big.
wow. Well, it sounds like we will all definitely continue to keep an eye on this. And I will certainly continue to look for words like misrepresentation and some of these other major words that you're sharing. It definitely will resonate more. So we're having some questions come in from the audience. I'm going to shift to that, and then we can get back to some of the questions that came in during the week. Is that okay with you, Glenn?
Of course, please.
Okay. So, Sandy, if you could unmute yourself.
Sure. Actually, Becca, I'm adding an extra part to my question. It's about testing, Glenn. First of all, we know that there are certain things involved with the coronavirus that if you snap your fingers and you need masks, they could be made. Maybe not N95 so easily, but they could be made for the population. Or if you needed to shut down, it could be shut down legally. That's as has happened in March. Conversely, when there is a vaccine, it's going to take a certain amount of time, and you really cannot rush it. But something like testing, we keep talking about how important the testing is. And is it possible that it's taking so long because it takes so long to make the tests? It's like a multi-question. There are a variety of tests on the market now. I know the White House is using these very quick tests. And is that something that is just physically hard to do, to make quickly in great quantity? And my other question, which is the one that I had mentioned to Becky, is I just heard about a new test that you test yourself at home. And I think it has a 75 to 80% accuracy rate. And I didn't know if the other tests that are currently on the market, the quick one and the one that we all, people line up in cars for, if that has the same percentage, and if that's the percentage of accuracy, is that going to help us control the virus? So it's two parts. One is making tests a difficult process that's taking so long? Or could we really get people to do that and then have enough tests and be this at-home test? And I will mute myself.
Yeah, so there's two main types of tests when we're looking at the virus. There are the PCR test, the polymerase chain reaction, and then an antigen test. The PCR, the way that it works is it takes a sample of the sample that you're looking at, and then it tries to amplify it. And you go through multiple cycles of amplification, and you might go through 30 or more cycles of amplification. So that's a lot. That's why it takes so long to run that kind of test. And then you're actually looking for strings of RNA and seeing if it matches with that string. And then it triggers it if you have a positive match. In contrast, the antigen tests are the rapid ones that we're looking at. And so those are, so an antigen is like, so in the immune system, whenever you're talking about an allergy or anything like that, the antigen is whatever the antibody binds to. And so it's essentially doing a test like that to see if you have binding with the antigen. And that's very rapid in terms of that type of test. The problem with the antigen tests is that they are not as effective or as accurate, let me say, as the PCR tests. But even the polymerase chain reaction tests, if you amplify it too much, then even that might not, it's harder to interpret. Like if you, there's a worry that if you were to amplify it, say 40 times or so, which some labs seem to be doing, then you're in there and it's hard to interpret if the person is actually actively shedding the virus or if they can spread it versus if it's maybe a remnant and they were sick weeks ago or something and it's just some additional viral shedding. And so it's still unclear. All epidemiologists are going to say more tests are better than none. We'd probably say that if you have a positive from any test, that it's a good thing to be aware that there's a positive, even if it's a false positive, because then you could self-isolate, quarantine for a couple of weeks, get a second test that would be more confirmatory in terms of it having a higher accuracy rate. And so typically another way of saying this, we talked about this a while ago now at this point, I can revisit it if you want, is this idea of sensitivity versus specificity, where sensitivity really tries to pick up any possible signal, even if it's not a real signal, just to try to find any possible signal that's out there, whereas the specificity of a test refers to the accuracy from the perspective of having false positives. You try to avoid it so that if you actually have a positive, that it's a real positive. Another way of saying this is sort of if you have a screening for cancer or for something else, the first screening might be an easy thing to do, where you might have a lot of false positives that are in there, but you want to try to avoid the false negatives and be more likely to identify someone who possibly has the disease. Then you would do a biopsy or another type of more sophisticated test that would then try to see if it's a false positive and really check to see what the disease is. It's the same type of thing here, where we want to be, we try to catch any positive and we're okay with false positive. What we're really trying to avoid are false negatives. And then you would hopefully have a second test that would then rule out to see if it's a false positive from the first test. But so the antigen tests are quicker, definitely better. We should be doing them more. If someone is negative with the antigen test, with the rapid test, it doesn't necessarily mean that it's a real negative though. And that's why we need to have a second test that might take a little bit longer with the PCR to see if they are actually shedding virus or not. But even shedding virus doesn't necessarily tell us much from a clinical perspective, because it's not necessarily infectious. The most important thing that it tells us is if someone has been infected recently, then it triggers us to do contact tracing, get other people tested, and get other people isolated and quarantined so we can stop the spread. But from a clinical perspective, it's a little bit hazy in terms of the interpretation, because just because someone is shedding virus doesn't mean that it's viable virus that can actually infect anyone else. And yeah, so there's a bunch of reasons, but yeah, so I don't know if that.
Does it take a long time to make those tests that would allow us to have enough testing?
Yeah, that's the big issue here, is that manufacturing the tests is hard, and there's not enough tests out there right now. And that's why there's a big backlog. That's why there's insufficient testing right now. We need more manufacturing capacity. We just don't have it, both for the reagents as well as for the different components that make up the tests. So some more are being made, but we need even more.
I forget what it's called, but the president has the authority that he says he has, that he enlisted himself with, that he could just say, Ford Motor Company, you have to make face shields. Novartis, you have to make more of these tests. Could he do that? Or it's not so easy still?
Yeah, no, it is easy. The federal government does have the authority under emergency situations to declare, yeah, and
Okay.
and that was a choice. I mean, if you might have been hearing over the last few months that the federal government of the United States has been trying to do less testing. And in fact, the CDC just this past week, symptomatic people should not be tested. And that's why there's a whole controversy. Everyone in the public health community says we should be doing more tests, not less tests. And
we shouldn't put too much stock in this at-home test when it comes out?
I don't know about the specific test that you're talking about, so I don't know. 80% accuracy, it might sound like it's accurate, but 80% is not very accurate relative to a lot of other tests. We're typically looking at above 95%, both in sensitivity and specificity for it to really be meaningful for us.
Okay.
But I don't know. I'll look into it for the next week.
I'll see if I can get the name. Thanks, Ben.
Sure.
Thank you. Unmute you. Harry had a follow-up question pertaining to testing as well.
Yeah, so you've kind of answered the question that I had. The origin of my question was from an article in the New York Times that indicated that there was too much testing that was actually finding people that were marginally infected because these people could not be transmitting the disease. So the question goes into what is the floor of a testing that would identify a person who is capable of transmitting? I don't believe that's a valid argument that the test is too sensitive to 5 people with low levels of virus in their body.
Yeah, I disagree with that New York Times article as well. I don't think I pulled it out here. But so basically it was saying, well, if you have to replicate the polymerase chain reaction 40 times to amplify it that much, you probably have insufficient viral load to really be meaningful in terms of spreading it to other people. But I disagree entirely, not with that fact, but epidemiologically, I think that if a person has been identified as having the virus, then the contact tracing infrastructure needs to be triggered. And just knowing that that person had the virus should be enough for us to make sure that we see who they might have come in contact with or not, depending on when they might have been infected and what they might have been in contact with. The other thing is that the viral load changes over time, and it might not be clear whether having a small amount of virus is after the infection has happened and it's in the tail end, or if it's at the beginning of the infection when there's just a very small viral load. And because of that, in the article, I went back and read it. I'm sorry I don't have it here. The viral experts, the virologists, had indicated that what they suggested was that people get tested twice if they have a small viral load. And we have this massive crisis of insufficient testing in this country. And so that's the whole issue here. We have insufficient testing. And so I have a different take than the folks in the article that were quoted. Epidemiologically, if someone has a viral load at all, then that's probably sufficient for them they should be getting a second test, but they should be self-isolating until we can know what's going on with them. And also to trigger the contact tracing infrastructure for that person. In much of the country, it's like I was showing you a little earlier, where the amount of outbreak is low, like in the Northeast of the United States, a positive test of any kind like that should be enough to trigger it to stop the spread. In much of the rest of the country where there's a big outbreak and the vast majority of people who are infected are not even getting tested at all, and there's insufficient contact tracing going on, then maybe the criteria should be a little bit different in terms of how we find a signal like that. But definitely for a best practice in like the Northeast of the United States, where we want to really find every single possible case and make them quarantine and test and trace them and test all the people they might have exposed or might have been exposed to, I would not throw out data like that. I would be testing more, not less.
Thank you for that great question, Harry. And Glenn, thank you for giving us fuller detail and helping us analyze what we're reading. It's very, very helpful. So we are approaching toward the end of our time together. I'm wondering if we could wrap up with just a couple more questions that have come in. First being, any more information on whether people can be reinfected? And then finally, thoughts about this second wave in the fall and the winter. You touched upon it a little bit earlier about starting at the new floor. Talk about
yeah. All right, so first about the reinfection question. So we've known for a while that people could be reinfected. I mean, the data was a little bit weird. The key way that we've identified someone who's reinfected is if they test positive, then they test negative for a couple of days in a row, and then time goes on and they test positive again. And so that's been interpreted as someone who was reinfected. It's not exactly clear if it's actually the case. Like, so for instance, what if someone was positive, the virus spread to a different part of their body, so they were no longer shedding virus in their nose or their mouth, but it was still infecting their cardiovascular system or their gastrointestinal system. But then it just came and the virus started shedding more again in the lungs or in the nose. It was unclear. And then that's frankly still unclear a little bit. What's new in the last week, so there were a bunch of reinfections identified based on, again, this positive, then a couple negatives, then a positive idea. But we didn't know. And because the virus is not mutating a lot, it's mutating a little bit, but it's not mutating a ton like the flu or other RNA viruses are. It's hard, if you look at the old genes, the genetic information of the RNA from the first virus versus the second, a lot of times they're identical. And so you can't use that to know if it's actually a new infection, like a reinfection, or whether it's just the old infection that just reemerged. And so what's unique here is that the genes, there's two interesting things here. So this is the first case in the United States that was identified as reinfection. And what they found were that the genes were actually different. So the RNA was slightly different, just enough that they could tell that it was truly a reinfection because it wasn't the same RNA as the original sample that was saved from that patient. The second thing that was really, the reason that a lot of people are alert about this now in terms of this case is that when the person was first infected in April, they had the traditional symptoms of sore throat, cough, headache, and also nausea and diarrhea. And so these were the traditional symptoms that someone might have when they first get COVID-19. But then after he recovered, 48 days later, when he was reinfected, the symptoms were more severe. And that is huge because the Hong Kong case, which was a few months ago, and other reinfections that people have been looking at, what you would expect is based on this idea of herd immunity, and herd immunity has to do with population level stuff. This is with the individual, is that if you're infected once, your immune system gives you protective immunity and protects you from either getting infected again, or if you are infected, it should make the symptoms less severe. And what's potentially alarming here is that in this case, when the person was infected the second time, his symptoms were much worse, requiring hospitalization. And if that's the case, then it's not a case of protective immunity at all. It's this idea that we might have been talking about earlier about a worse impact. That that the first exposure might stimulate your immune system and that give you an adverse immune response later on if you're infected again, as opposed to a protective immune response. And so what we have here was an adverse immune response. We don't know exactly what was causing it. Was it maybe the strain was slightly different and that caused it? Was it the more severe symptoms, that required hospitalization? Was it due to an initial stimulation of the immune system that triggered it the second time? We don't know yet. So a lot of people are paying attention to this. It's just something that we're going to be following. there have been millions of people infected with COVID-19 at this point. And so we don't know at the population level how common this is yet. And we also don't know whether someone who's infected a second time or more can spread it, which is the big question for the herd immunity threshold, whether people can spread it again. But that's all that we know here. So yes, it is an issue that we have to keep track of, but we don't know at the population level epidemiologically what it means exactly yet. I do have some good news if we want to end on some good news this week. So I don't know if you want me to answer the other question first that you had, or whether
Let's save the good news for the end. So I'm not sure I anticipate how you'll be answering what you expect will be happening in the fall and the winter, but you decide the order.
Well, so this is, yeah, so will there be a second wave? So most people are thinking yes, there's going to be a second wave for the same reason that we're seeing a new spike in the colleges and university. There's more social mixing. As fall and winter come, the traditional time of year for the flu, the environment is more, it's easier for a respiratory virus to spread. The humidity level in the air goes down, which promotes the spread of respiratory virus. People are indoors, and that makes an aerosol easier to spread around without the mixing of the air outdoors. It's harder to keep physical distancing indoors for a lot of people. So for a bunch of reasons, we do expect that there's going to be an increased wave. If there's, depending on how people respond, I mean, I don't know, we might see variation across the country in terms of what waves look like. So for instance, if there continues to be more mask wearing, if there is more physical distancing and people aren't gathering in large crowds, then that might make it less likely that we have big surges. We can talk about a second wave in the Northeast, because we truly did have a very clear first wave. Then the infection rate came way down, and so then we would be talking about a true second wave. Whereas in much of the country, it's more surges rather than waves that we're talking about. But now, so here's the good news. I'll add it on. So this was a question that came up a couple months ago in terms of flu. Like, if we're doing all of this physical distancing and we're wearing masks all over the world, wouldn't this reduce the amount of flu as well? You would think that if flu is spread by the respiratory route, and the same way that COVID-19, that the SARS-CoV-2 is spread, wouldn't you see a reduction in flu? And as it turns out, we're seeing an enormous reduction in flu globally. A map like this looking at flu usually is much more colorful. And what we're seeing here, to a lot of people's great excitement, epidemiologists around the world are rejoicing. I don't know if we're actually rejoicing, but everyone's very happy that the flu has reduced dramatically. And this is good for a couple of reasons. One, it's a good indication in the Southern Hemisphere that there is physical distancing and mask wearing and things that are working. And it's practically disappeared. That's great. So that means that we can probably expect, if we do wear more masks and continue physically distancing in the fall and winter, that there will probably be less flu. And one of the concerns I voiced in the last few weeks and months was that flu and cold have different symptoms than SARS-CoV-2. And one of the signs and symptoms of flu and cold are sneezes. And if you have a respiratory disease with sneeze that could potentially propel the virus much further, then that might actually increase the R value, the effective R. But if there's less flu and less comorbid flu, then maybe it won't put us as high risk for having comorbidity that I think we saw a fair amount of, not a huge amount of, but some back in March that might have contributed to the spread. So this is really good news. One thing I do want to point out, so you see here on this map that flu is really dramatically lower. Whoops, so flu is dramatically lower in the Southern Hemisphere, which is good, because it's the Southern Hemisphere that spreads in the winter, or fall and winter in the Northern Hemisphere, that gives us our flu season. So for a couple of reasons. One, there's going to be less virus seeding the northern hemisphere, so that's going to be good. There's going to be less entering. But then two, the very same suppression that's occurring in the southern hemisphere will also be occurring in the northern hemisphere. So we're probably going to have one of the best, and by that I mean one of the least strong flu seasons that we've had in many years. But having said that, I do want to come back to what I've shown you a little earlier tonight, which is this, which is this one. And so when you look at the spread in the southern hemisphere, let's take Argentina as an example. Argentina, so this is the southern hemisphere, this is winter time there. You see that despite the amount of flu has been less, so it's demonstrated that they've been successfully wearing a little bit more masks and physically distancing a little bit. We see that they've just been dramatically increasing in spread in Argentina. And it's the same kind of story across the southern hemisphere. And that's why a lot of us, when we're thinking about the fall and winter in the northern hemisphere and in the United States, and particularly the northern states where we have more of the winter conditions, this is what we're looking at. We see that this is what we have always been looking at as a sort of a precursor to what we would be expecting in the northern hemisphere. And it could have gone a different way. It could have been that it was a short spike. It could have been that they achieved some sort of herd immunity sooner and we didn't see it, but their numbers are just continuing to rise. And so hopefully their season will end, and they'll be approaching spring and summer soon, so their numbers will start to go down. But when you look at like Brazil even has been fighting this really hard. It's been going up and up and up, and then you think it might start going down, but then it goes up again. It's because the effective reproduction rate goes up in winter. So it's not the same R value that we have all year round. During the summer, the R has come way lower, so it's even easier to more effectively prevent with masks and physical distancing. But when the R value goes up higher, it's much harder to prevent the spread. And so you can make errors, like if over the summer, you can make mistakes, maybe not wear the mask all the time and maybe get closer to people than you should. But the virus is more forgiving because the R value is lower. In the winter, the virus is less forgiving and it's much easier to catch, much more contagious. And it's not a virus thing. It's more of these other things that I've cited in terms of people being closer indoors and other types of things that I mentioned. The virus is the same virus. The genes are essentially the same. It's more of a personal behavior type thing I'm talking about, and even some of the cultural things that in terms of the variation. But yeah, so Chile looks like they're doing better, but even them, they still have a pretty high rate relative to where they were. Anyway, that's where we were. But the good news is flu has gone way down, and flu itself does kill people independently, kills tens of thousands of people in the United States every year. And if we have less flu, that is going to be fantastic. But having said that, everyone should get their flu shot as soon as they can in the coming weeks, and just to be on the safe side.
That is fantastic news. And I am rejoicing, even though I'm not an epidemiologist, can I join with you all in rejoicing, because that is fabulous news. I've never rejoiced over the flu or the lack thereof in the past, but I'm putting those words in the same sentence, just like you. So I'm going to go get my flu shot this week. Anyone else getting their flu shot this week? Or maybe you already did. Oh, you did? I see thumbs up. Excellent. Okay. So flu shots are all around this week. Everybody be safe, be well. And Glenn, thank you as always for your time and your expertise. We really appreciate being with you.
Thank you. Likewise.
Monday.
Thank you. Bye-bye. Have a great week.
You too.